Okay, in our video series of cardiology lectures, in this video we are going to talk about pericardial effusion and cardiac tamponade. We are going to talk about its presentation, its causes, diagnosis and management of cardiac tamponade in detail. First of all, we have a case here. A 72-year-old man with a history of lung cancer comes to your clinic complaining of shortness of breath. Doctor, I cannot breathe. Doctor, there is also chest pain. There is chest discomfort in the patient. When you examine the patient is having muffled heart sounds. You cannot listen to the heart sounds properly. When you examine the patient's blood pressure, the blood pressure is low. The patient is having hypotension. When you look at the neck veins of the patient, the neck veins are distended. The JVP is elevated. When you perform the chest x-ray of the patient, you see an enlarged cardiac shadow, a big heart. When you perform the ECG, you find that the QRS are having different sizes. In the same lead, some QRSs are big and some QRSs are having low voltage, electrical alternance. When you perform echocardiography, you find out that there is a lot of fluid accumulated around the heart. This is a case of cardiac tamponade. What is cardiac tamponade? What is pericardial effusion? Today we are going to talk about that. Now, first of all, you need to know that our heart is surrounded by a layer called as pericardium, and this pericardium protects the heart and lubricates the heart. This layer of pericardium is composed of basically two layers: the parietal pericardium that is present on the outer side and visceral pericardium that is attached to the heart tissue. And between the parietal pericardium and visceral pericardium, there is pericardial cavity. This is the pericardial cavity. Over here, there is lubrication present that allows the heart to contract and relax properly during the heartbeats. Within this pericardial cavity, sometimes the fluid can accumulate, sometimes the blood can accumulate. Sometimes the pus can accumulate. Whenever any type of fluid accumulates between the parietal pericardium and visceral pericardium, that is called as pericardial effusion. Effusion around the heart within the pericardial cavity. Pericardial effusion is an acute or chronic accumulation of fluid in the pericardial space between the parietal and visceral pericardium. It can occur acutely, where there is sudden accumulation, or it can occur chronically, where there is accumulation of fluid over the period of time. Whenever it occurs acutely, the patient is very symptomatic. Whenever it occurs chronically over a long period of time, a large amount of fluid can accumulate in this pericardium and the patient has no symptoms because it gives time for the pericardial tissue to relax. So, if it develops acutely, even a small amount of fluid in the pericardial cavity can cause severe symptoms. But if it occurs chronically over a long period of time, even a lot of fluid accumulates in the pericardial cavity, the patient still does not have any symptoms. This is pericardial effusion. Now, what is cardiac tamponade? Cardiac tamponade is elevated intrapericardial pressure that causes compression of the heart, especially the right side, the right ventricle. Now, in this picture, you can see this is a normal heart with a normal pericardium with no fluid outside it. But over here, you can see around the heart, there is a lot of fluid accumulation in the pericardial cavity. And whenever there is a lot of fluid present around the pericardial cavity and it compresses the heart, when it compresses the heart, it causes symptoms that is called as cardiac tamponade. So pericardial effusion, if it is causing no symptoms, then that pericardial effusion is benign. But if a pericardial effusion is accumulating and it is compressing the heart, then it causes cardiac tamponade. It compresses the right ventricle because right ventricular wall is thin and it is compressed easily. Now, coming to the etiologies of pericardial effusion. In the etiologies of pericardium, remember there can be blood accumulation in the pericardium. During the heart surgeries, blood can accumulate around the heart, or after an MI, ventricular rupture, ventricular wall rupture can take place that can cause accumulation of blood in the pericardium, resulting in hemopericardium. Or there can be a serous effusion, a non-infective effusion with less proteins in it, especially in congestive heart failure, hypoproteinemia, where there is leakage of fluid into the third spaces. A space where the fluid can also accumulate is the pericardial space. Therefore, serous effusions can be seen. Serosanguinous effusions, where there can be seen exudative effusions with a lot of cell counts, a lot of neutrophils, a lot of lymphocytes in the effusion with a lot of proteins, especially seen in tuberculosis, especially seen in neoplastic diseases with malignancies. These effusions can accumulate, and these effusions, if tapped, can really help you in the diagnosis of systemic conditions. So these are important causes of pericardial effusion. Now, this is a picture showing a normal healthy heart with a normal pericardium around it where there is no fluid. The heart can contract and relax normally. Now, what happens in cardiac tamponade is that there is a lot of fluid accumulation around the pericardial cavity, and that effusion causes compression of the heart. That effusion compresses the right side of the heart, especially because the right side has thin wall. Left ventricular wall is thick, therefore it is less prone to compression, whereas the right ventricular wall is thin, therefore it is more prone to compression. When the right ventricle wall is compressed by this fluid, it transmits this pressure to the interventricular septum. This pressure is transmitted to the interventricular septum, and it pushes the interventricular septum towards the left ventricular side, and the left ventricular cavity size decreases. When the left ventricular cavity size decreases, the left ventricle cannot fill up with the blood properly because the cavity size is decreased due to the compression. When the left ventricle cannot fill up with the blood properly during the diastole, it will not pump out enough blood to the body. When enough blood is not being pumped out to the body, the patient will experience hypotension. There will be decreased cardiac output in cardiac tamponade. Therefore, in our case, with the patient that presented to us with cardiac tamponade, the patient was having hypotension. Increased pressure in the pericardial space causes compression of the heart, especially the right ventricle due to its thin wall. Interventricular septum also gets pushed towards the left ventricle, therefore there is decreased cardiac output. Now, a very important point is that there will be equalization of end diastolic pressure in the all four chambers of heart. This is a very high yield point. Now, understand that there are different pressures in all four chambers of the heart. There are different end diastolic pressures when they fill up with blood. The atria have different pressures, the ventricles right and left have different pressures. During a cardiac tamponade, there is blood accumulated, or there is fluid accumulated around the heart that is squeezing the heart, that is compressing all the chambers of the heart. Whenever the fluid is squeezing the heart, the all chambers cannot fill up with the blood properly. Therefore, all the four chambers have normal equal end diastolic pressure. All the four chambers have the same end diastolic pressure due to this external compression by the fluid. Therefore, you will see equal end diastolic pressure in all four chambers due to this external compression, the external pressure that is outside there in cardiac tamponade. This is a very high yield point. Now, coming to the clinical presentation. In the clinical presentation, it's important for you to understand that even if a small amount of fluid accumulates in the pericardial cavity suddenly, that can cause symptoms because it will not let the pericardial cavity relax over the period of time. It does not allow enough time for the pericardial cavity to adapt to the fluid. Therefore, even a small amount of fluid, when it accumulates suddenly, it causes cardiac tamponade and it causes symptoms. But if it develops over a period of time, if the pericardial fluid slowly and gradually accumulates in the pericardial cavity, then it allows the pericardial cavity to relax with the time. And even if there is liters of fluid present in the pericardial cavity, sometimes the patient are asymptomatic because the pericardial cavity over the period of time has stretched so much that it has made space for this fluid. Therefore, this is a very important point for you. Patients can be asymptomatic. When they are having symptoms, there will be shortness of breath when lying, there will be orthopnea, there will be retrosternal chest pain due to compression of the heart. Now remember, if there is fluid present around the heart, that fluid can even compress the adjacent structures. If it compresses the recurrent laryngeal nerve, it causes hoarseness. If it compresses the diaphragm, it causes nausea. If it compresses the esophagus, it causes dysphagia. If it compresses the phrenic nerve, it causes hiccups. So this is a presentation of patient with pericardial effusion and cardiac tamponade. Remember, apical pulse is difficult to locate, or sometimes it's even non-palpable. When you try to locate the apical pulse in these patients, Due to a lot of fluid present around the heart, you cannot palpate it, you cannot feel where is the apical pulse. And when you listen to the heart sounds, you won't be able to listen to the heart sounds properly, because there is a lot of fluid that is present around the heart that is dampening the effects of the sounds. An important sign that you would see in these patients is Ewart sign. What is Ewart sign? Basically, a heart is present in the left side of the chest cavity, and when there is pericardial effusion developing around the heart size will increase and it will compress the adjacent structures. The increasing size of the heart will compress the lower lobe of the left lung. When it compresses the lower lobe of the left lung, this compression leads to atelectasis of the alveoli of the left lower lobe. When the alveoli collapse, this can result in consolidation. Atelectasis and consolidation of the left lower lobe can be seen in these patients. And when you examine these patients, you will find dullness to percussion at the base of left lung, and there will be increased vocal fremitus. When you listen to the patient's chest, left lower lobe, and you tell them to say 99, you could clearly see 99 in your ears, which is not normal. This is seen in consolidation. This occurs in consolidation. And there will be prominent breathing sounds, the bronchial breathing that is seen in consolidation. So these are the important points that you need to remember at the examination finding, that is the Ewart sign, a combination of dullness to percussion, increased vocal fragments, bronchial breathing due to atelectasis, and consolidation of the left lower lobe. Everything makes sense when you know the pathophysiology. It's very important for you to understand pathophysiology if you want to learn medicine, because all the clinical presentations would make sense to you, all the diagnosis and treatments would make sense to you, because you know what goes wrong. When you know what goes wrong, everything goes right. Now, whenever there is fluid accumulating in the cardiac tamponade, it causes compression of the right ventricle, and whenever there is compression of the right ventricle, this compression is transmitted to the left ventricle, and the left ventricle cannot fill up with the blood, therefore it cannot pump enough blood to the body, and you would see hypotension in these patients. With hypotension, what you would see is that since there is compression of the right side of the right side of the heart can also not fill up with the blood properly, and the veins that are draining to the right side of the heart will be distended. The JVP will be distended, the veins will be distended, the neck veins are distended. This is seen in cardiac tamponade. And with that, when you auscultate the patient's chest, you won't be able to listen to the heart sounds, because the heart sounds are muffled due to the fluid that dampens the sound, and the muffled heart sounds can be seen. This is a triad that is called as Becks Triad. Becks Triad is diagnostic for pericardial effusion. Becks Triad has hypotension, muffled heart sound, and distended neck veins, commonly tested point in exams. Now, coming to the Pulsus Paradoxus. Pulsus Paradoxus is the topic that many students fear and they struggle to understand. It's a very simple concept. Everything will make sense when you understand the pathophysiology of Pulsus Paradoxus. Basically, what happens is that when we inspire air and when we expire the air, when we inhale and when we exhale, there are certain changes that occur in the heart. These changes are normal physiological changes during inspiration and expiration. Whenever we inhale the air, the chest cavity expands. When the chest cavity expands, it creates a negative suction pressure in the chest, and that suction pressure would open up the heart, and that would cause the right side of the heart to fill up with blood properly. So whenever there is suction pressure developing in the inspiration phase, the right side of the heart would fill up with blood much more as compared to the expiration phase. In the inspiration phase, the right side of the heart would receive more blood because there is increased suction pressure in the inspiration phase. During the expiration phase, there will be compression of the right side of the heart because the right side has a thin wall, therefore, the right side is more prone to compression. So, the right side cannot fill up with the blood properly in the expiration phase. So, there is a slight increase in the blood filling during the inspiration phase as compared to the expiration. This is a normal change that occurs during the inspiration and expiration. Now, during the inspiration, when there is suction developing in the heart, the right side is opening up and right side is receiving more blood during the inspiration phase. What it would cause is that it would compress the interventricular septum and the left ventricular cavity size would slightly decrease as compared to the expiration phase. So when the left ventricular cavity size decreases during the inspiratory phase, it cannot fill up with the blood as much as it fills in the expiration phase. Therefore, when it pumps out the blood during the inspiration phase, the systolic pressure that it generates during the inspiration is lesser as compared to the systolic pressure that it generates during the expiration phase. That difference is normally around 5 to 10 milligram. The pressures, the systolic pressures during the inspiration phase are 5 to 10 milligram higher than the systolic pressures that are generated during the expiration phase. If this systolic pressure is greater than 10, then that is called as pulsus paradoxus. Now, in what situation can this difference increase? It can increase in a situation like cardiac tamponade. In cardiac tamponade, blood accumulates around the heart, and during inspiration, while this right side of the heart is filling with blood and causing compression of the left ventricle, now another factor is also contributing to the compression of the interventricular septum, and the cardiac tamponade, the fluid around the heart, would also contribute to compression of the interventricular septum and would cause further reduction in the systolic pressures during the inspiration. Therefore, the drop of blood pressure during the inspiration would be greater than 10 mm of Hg. That is called as pulsus paradoxus. So pulsus paradoxus is very easy. Pulsus paradoxus is drop in blood pressure of greater than 10 mm of Hg during the inspiration phase, because initially there was just one force that was causing the interventricular septum to be pushed, but whenever there is cardiac tamponade that is also present, would also cause increased compression of the left ventricle. So that is pulsus paradoxus. Diagnosis of pericardial effusion is very simple. Echocardiography, transthoracic echo, is the gold standard test for the diagnosis of pericardial effusion. Unlike pericarditis, where in pericarditis we did ECG to diagnose the pericarditis, in pericardial effusion we perform the echo to diagnose pericardial effusion. In the supporting investigations, when you perform ECG, what you would see is that there will be electrical alternance. What is electrical alternance? Electrical alternance is the difference in the size of QRS complex on an ECG. Some QRS complexes will be small, some QRS complexes will be bigger, some are small, some are bigger. Why does this happen? Basically, since there is fluid accumulated around the heart is moving constantly in that fluid filled cavity. In that fluid filled balloon, the heart is dancing all the time. So now lead 2 is present over here, trying to catch the signal of the QRS complexes and trying to record them in the ECG. Now, when in some cases the heart is present directly in front of the lead 2, the apex is present directly in front of the lead 2, and you would see a beautiful big QRS complex. In another case, in the next beat, the heart would move above or below, and in that situation, the apex is moving away from the lead 2, and you would see a smaller QRS complex. So, you would see electrical alternance, you would see small QRSs and big QRS complexes. This makes sense when you know how to do ECG. I have explained, I have a whole playlist on ECG lectures. You can check out the link of those videos in the description below. So this is a picture showing electrical alternance, QRS complexes that alternate in height due to swinging motion of the heart, the dancing motion of the heart in the chest. This is another picture showing the electrical alternance. Look over the QRS complexes. You can see the different sizes of the QRS complexes. In the supporting investigations, when you perform the chest x-ray would show water bottle sign. Look at the massive heart. It looks like there is a water bottle present in the heart. Look over here, the water bottle sign, massive heart. And now remember, if you are able to see a massive heart in pericardial effusion, if you are able to detect pericardial effusion on a chest x-ray, it means that this pericardial effusion is greater than 250 ml. Because for a pericardial effusion to be detected on an x-ray, it has to be greater than 250 ml. So if you see it on x-ray, it's definite that it is more than 250 ml. Now, another supporting investigations that you would do in these patients is pericardial fluid analysis. Now, in many cases, you would know the cause of pericardial effusion, like if the patient had a cardiac surgery and after the cardiac surgery, the person has a minimal effusion. It's common. It's a commonly seen scenario that patients get a pleural effusion after a cardiac surgery, but that is benign. Now, in many cases, you would not have any cause of pericardial effusion, but the patient is having pericardial effusion. In such cases, what you do is that you tap the pericardial fluid and you perform certain tests. You do the cell counts, you do the gram staining and cultures. You see which cell is predominantly there, whether it is an infection, whether it is lymphocyte predominant, whether it is neutrophil predominant. You do the gram staining and culture to detect the bacteria. You do the cytology to rule out malignancy. You do the acid fast bacilli test to rule out tuberculosis in these patients. It does not have any specific criteria, but you can take help from the light criteria that we use in pleural fluid analysis, and you can apply light criteria in this scenario as well to find out the cause of pericardial fluid infection or any other cause of pericardial fluid accumulation. But remember, echocardiography is the mainstay and gold standard investigation for pleural effusion, and ECG for pericarditis. Now, coming to the treatment of pericardial effusion, treatment of pericardial effusion depends on whether the patient is stable or unstable. If the patient is unstable, the patient is not maintaining blood pressure, the patient is having severe shortness of breath, severe chest pain, and has come to you in emergency, is having muffled heart sound, distended neck veins, low blood pressure, the Becks Triad is there, you need to immediately remove the fluid from the pericardial cavity. You have to perform therapeutic pericardiocentesis. In therapeutic pericardiocentesis, what you do is that you put the echo probe on the heart, you look at the pericardial cavity, and you pass a needle and you remove the fluid. This is just a procedure to remove the symptom, to relieve the symptoms of the patient, to stabilize the patient. This is not a definitive treatment, but this is a treatment that can help stabilize the patient for some period of time, because most of the time when you remove fluid like this, after sometimes they again get reaccumulation, so you have to treat the cause of fluid accumulation. But in emergency, when the patients are unstable, you immediately remove the fluid. If the patient is stable, in such situation you have to see whether it is a small effusion or it is a large effusion. On echocardiography, you can see how much fluid is there around the heart. If it is a small effusion, in small effusion you can wait and watch for some period of time. Like in cases where a patient had a surgery, cardiac surgery, and now has a small amount of effusion, the patient is not having symptoms, you would wait and watch, and the fluid would be reabsorbed by itself. Or if the patient is having a certain condition and you know the cause of the pericardial effusion, if the patient is having hypoproteinemia, if the patient is having congestive heart failure, and you know that it is not causing any symptoms, you treat the disease and the effusion goes away. But if it is a large effusion and it is causing symptoms, in that case you have to go for pericardiocentesis. Now, what are the procedures that you can do in pericardiocentesis? You perform pericardiotomy. In pericardiotomy, a hole is created in the pericardial cavity so that there is a constant drainage of fluid, because it's a problem that many times when you perform pericardiocentesis, where you take out the fluid accumulates again. So what you do is that you put a hole in the pericardial cavity. That permanent hole is there so that the pericardial fluid keeps draining out. It can drain into the pleural space, it can also drain externally. So you put a passage for it, the fluid to drain constantly. That is called as pericardiotomy. Balloon pericardiotomy is also done. In balloon pericardiotomy, they pass a catheter and a balloon is inflated to create a hole in the pericardial cavity. Pericardiectomy can be done especially in the cases where the patient has developed constrictive pericarditis, where the layer has become so tough and hard, and that has resulted in fluid to accumulate in it. So in that cases, you tear away the pericardial layer, and you can do a partial removal, or you can even do a complete removal of the pericardial layer to treat the pericardial fluid. But remember, it always depends on the cause of pericardial effusion. You do not have to go for these type of procedures in majority of the cases. In 70% of the cases, you would see that when you treat the cause, the pericardial effusion goes away. So you have to treat whether it is tuberculosis, whether it is malignancy, whether it's congestive heart failure, whether the patient is having autoimmune effusions. So you have to treat the cause. In the cases where you are unable to treat the cause, or if there is large effusion that is resistant to treatment, in such cases you would go for such surgical procedures. So you have to have cardiac surgery department and cardiology unit on board when you are going ahead with the treatment of pericardial effusion. It is important to remember that acute pericardial effusion with pericardial tamponade is a life-threatening condition. It's an emergency. The Becks Triad is there. You have to perform immediate pericardiocentesis and you do the pericardial decompression. Whenever a patient comes to you, you have to consult cardiology, you have to perform immediate echocardiography. If the patient is unstable, perform pericardiocentesis urgently. Continuous monitoring should be done in these patients. If the patient is hypotensive, you can give cautious fluid, but remember pericardiocentesis is the mainstay. Consult the cardiac surgery unit for further management, definitive management, and serial pulsus paradoxus measurement should be done because that would indicate how much fluid is there in the chest. Before going into the summary, if you like my video, please click on the subscribe button and make sure to check out my other videos on cardiology lectures, ECG lectures, emergency medicine lectures. If you want to support this channel, you can support this channel on Buy Me a Coffee. We talked about what is pleural effusion, what is cardiac tamponade, the causes of pericardial effusion and tamponade, the pathophysiology by which it causes decreased cardiac output, how it causes symptoms, the compressive symptoms, what is Ewart Sign. We talked about the Becks Triad. We talked about Pulsus Paradoxus. Greater than 10 mm of Hg drop in blood pressure during inspiration is abnormal. Echocardiography, the gold standard test, electrical alternance on ECG, water bottle sign on chest X-ray, pericardial fluid analysis for the diagnosis. If the patient is unstable, do pericardiocentesis. If the patient is stable, in such cases, you have to treat the cause. If patient it is resistant, then you go for pericardiotomy or pericardiectomy. If you like my video, please click on the subscribe button and make sure to check out my other playlists. Thank you very much.